Good morning, everybody, and thank you all for joining. It is indeed a pleasure to be collaborating with AIM Melanoma to present this symposium today. And folks who treated melanoma over the last 15 years have seen unprecedented change or impact on the outcomes in this rather dreaded disease. And in the next couple of hours, the effort is going to be to kind of update everybody on how best to deal with it. Now, here, what I'm trying to show you is what has happened to the incidence of melanoma over a period of last 10 years. So you can see in the graph that is on top, the incidence of melanoma has steadily increased over the last 10 years. But interestingly, what you can also see that the mortality over time has decreased. And this has largely come from development of multiple immunotherapy and targeted therapy agents listed out here and when they were approved. So there has clearly been impact of the therapeutics on the outcome of disease. And that is why we feel it is very appropriate that we now have in the caption living with melanoma. So today, what we're going to be doing is we'll talk about a patient who has newly been diagnosed with melanoma and how best to deal with that. It is a time of great anxiety and confusion, and go through the continuum of the disease process and options. Dr. Atlas, my colleague, she is an assistant professor of medical oncology at Wake Forest and Atrium, and she will be touching on the toxicities associated with the melanoma treatments. My colleague from surgery, Dr. Malcolm Squires, is assistant professor in surgical oncology, is going to update us regarding surgical management of melanoma in 2023. Jessica Davis is our PharmD, and this is indeed an important aspect of management, and that is the financial toxicity of all these. These treatments are effective, but they can be horribly expensive. So she will update about that. And then Anne, as she alluded earlier, is going to provide us with some additional information and patient resources to tap into, and then we will have the Q&A session. So with that, let me start off with the patient perspective for melanoma. So I am at the Levine Cancer Institute in Charlotte. I'm the section chief for cutaneous malignancies, and I'm a medical oncologist. What I thought we would cover is new diagnosis of melanoma, what surgery to do that Dr. Squires is going to elaborate more. What is adjuvant treatment? What is neoadjuvant therapy, and when to consider that? If there is recurrence of disease, how to tackle that? What are the options for advanced disease? And Dr. Atlas is going to be elaborating more on that. And then just brief mention on the less common presentations of melanomas. Those are the mucosal melanomas and the ocular melanomas. So this is a continuum of diseases I see it. On the left side of this ongoing continuum is the early stage 1 disease, and then the late stage 1s, early stage 2s and 3s, and stage 2s and 3s that are more advanced, and then the recurrence in stage 4 disease. So the way I kind of try to present out here for better understanding is red is local. What we have are two modalities really or two steps in which we manage disease. This is local control that is either with surgery or radiation, and that is more important with the earlier stage of disease. I don't know if you can see my arrow kind of slashing through this. And then the systemic control, that is immunotherapy and targeted therapy. We sometimes use chemotherapy now, but not as often. And that is more for the stage 4 and the advanced disease. So that is kind of how we'll use the same diagram to go through different stages of disease. So let's start off with this 45-year-old gentleman who recalls having a mole on his left arm for a long time. And then over a period of 6 months, this became more prominent. It changed shape, it became flaky, and it became itchy. So those are the typical A, B, C, D, E's of melanoma. If there's a pigmented lesion or a mole that starts changing, it has irregular borders, it has irregular colors, the size is more than the diameter of the eraser on the pencil, and it is changing. So he did seek medical advice, a shave biopsy is done, and that showed melanoma. So now, all of a sudden, this is a diagnosis of potentially lethal outcomes, and what are we going to do with that? So the first step is to do risk assessment. So risk assessment is based on 3 factors: the tumor, the nodes, and we'll talk about that a little bit, and the metastasis. When we talk about malignancies, what it essentially means is that one of the normal cells became abnormal and started dividing without any control. And depending on where in the body that cell was, determines what kind of malignancy. So if that cell, this is a cross-section of the skin, so if that cell lived in the outer layer of the skin, and this cell is called a melanocyte that is darker in color because it contains a pigment called melanin, then it makes a melanoma. So if the melanoma or the tumor that you can see out here in the cross section, if it is confined to the skin only, then it is stage 1 or 2. And if it has traveled, the other characteristic of tumor cells is that they can travel, go elsewhere, and take new exits and make new colonies. So if they travel locally on side roads, and these side roads are called lymphatics, the little green channels that you see, and they're spread all over the body. And along these green channels, you see little immune system check stations, and these are called lymph nodes. So if they have traveled to the local lymph nodes, then it becomes stage 3. And if they decide to travel along the bloodstream, that is the highway system in the body, then all bets are off where they can go. So they can go to any organ system, and that's stage 4. So that is called distant metastasis. So in general, when we talk about the risk in early stage disease, it is dependent on 2 factors. The thickness, how thick the melanoma is. Look at this lesion on the top, and look at this lesion, how deeply it invades into the skin, and whether it is ulcerated or bleeding. So you can see this smaller lesion is not ulcerated, and the larger lesion has an area of bleeding or skin breakdown. So those are the things to be kept in mind in terms of risk assessment. Now, how do we manage that? So, earlier the melanoma, the thinner the melanoma, the lower risk the melanoma on the left side, the local control can result in cure. It can translate into cure. So adequate surgery, and Dr. Squires will likely elaborate more on that, with adequate margins all around the primary lesion, can result in or translate into cure. In some instances, additional local control with radiation may need to be considered. So that WLE stands for wide local excision. Now, as the melanomas become deeper, remember thickness of the melanomas or ulceration or bleeding of the melanomas adds to the risk, then we need to see if these cells have traveled elsewhere in the body. So now we need to find out if the local lymph nodes are involved, and that is by mapping out where is the flow of fluid from that area and isolating those lymph nodes. And then if it is a very high-risk lesion and there are multiple lymph nodes involved, then the systemic control now becomes important, either before surgery, that is called neoadjuvant, or after surgery to reduce the risk of recurrence. And that is usually for a period of 1 year, either immunotherapy or targeted therapy. So in that continuum of management, what we saw was for the early stage 1 disease, wide local excision only is adequate. These are very thin melanomas without any high-risk features. So local control translates into cure. For the late stage ones, so the little thicker melanomas, early stage 2s or 3s, now we do need to find out if they've traveled elsewhere. So the Sentry or Sentinel lymph node mapping would be warranted. And then depending on this, on the how risky they are, there would be consideration of systemic control for a year. For the late stage 2, that are really thick melanomas that are ulcerated, or the stage 3 melanomas that have spread to the local lymph nodes, we may need to, based on the stage, how risky it is, based on that, we may need to consider either neoadjuvant treatment, that means treatment prior to surgery, and we'll talk a little bit about that in a second, or definitely considered folks to reduce the risk of recurrence after their surgery with adjuvant treatment. Okay, that is immunotherapy or targeted therapy. So we've kind of dealt with the early stage disease that is confined to the skin or to the lymph nodes. Now, what is adjuvant treatment? And why do it? So this is treatment after the surgery is completed. So if everything is resected, if everything is already out, why should there be any further treatment? You know, these are curves, and I don't want to belabor much, but I just want for you to see that these are folks who have stage 3 disease, and this is time in years on the bottom and melanoma-specific survival on the vertical axis. So higher the curve, more people alive, lower the curve, more people have mortality. With stage 3, B, C, D disease, you know, and again, we're not going to go into details of that, but higher the risk of disease, now that we have effective treatment options, there is adequate evidence to suggest that the risk of recurrence and death can be decreased. And this is the data for immunotherapy. Immunotherapy is, again, Dr. Atlas is probably going to be elaborating more, but this is using drugs that enhance the T cell activity and make the tumor environment more amenable to the tumor cells being killed by the T cells. The T cells are the guys that are part of the immune system that go and kill tumor cells. Again, on this graph, the horizontal line is time in months, and the vertical line is the relapse-free survival. All I want for you to kind of remember is that when we use immunotherapy, and that's this green line up here, the green curve, as opposed to an older immunotherapy, there is clearly a benefit for the newer immunotherapy with more folks being relapse-free at 5 years. 60 months is the 5-year time point. The same effect is observed if we use targeted therapy, and this is with BRAF and MEK inhibition, and we'll talk about a little bit about that. Some melanomas have a particular mutation, and that mutation can be targeted with oral agents and elicit responses. Again, the 60-month data, that is the 5-year data, this is time in months, and this is patients alive without any relapse on the vertical axis. The blue curve are the folks who got treatment, and the red curve is who did not. And again, there is clearly an advantage getting treatment in terms of the 5-year relapse-free survival. So high-risk disease, consideration for 1 year of treatment after surgery is completed. Now, let's go to the next kind of stage where we're now talking about recurrence of disease. And that recurrence can be very local or limited, or it can be advanced, or it can be distant, which is stage 4 disease. So going back to our example, the patient got appropriate surgery initially. There was stage 1 disease, so all that was required was surgery. No adjuvant treatment was, so no immunotherapy or targeted therapy was needed. 5 years later, the gentleman presented with a little lump in that scar. So here's the scar, and here's that little recurrence. Scans were obtained and a biopsy done, and the biopsy showed this to be melanoma. So now, because this patient did not initially merit consideration for adjuvant systemic treatment with immunotherapy, now that this is a limited kind of recurrence, this can be taken off with local control using surgery, and then should be offered adjuvant treatment to reduce the risk of further recurrence. But sometimes the recurrences can be advanced. The same patient got the same surgery, stage 1 disease, was not treated with adjuvant immunotherapy upfront or adjuvant targeted therapy. 5 years later, now presented with a lump under the armpit. Now, this is a PET scan. So this is the PET scan. We're looking at somebody from front to back. There are some areas in the PET that light up normally. So this is the brain that should light up, and that is normal. This is the right arm, this is the left arm, and under the left arm, there's this large area of activity. This is the right lung, left lung, and heart. So there's a large area of activity that we see under the left arm, and that is biopsied and is melanoma. Now, with that amount of tumor burden, there should be consideration for what is called neoadjuvant treatment. So what is neoadjuvant treatment? That is treatment before surgery is done. And the goal out here is to reduce the tumor size prior to surgery. That may decrease the morbidity of the surgery, and Dr. Squires may be elaborating on that later. It also, importantly, helps us tailor future treatments. So if we use for a limited period of time, say 6 weeks or 8 weeks, we use a modality, we use either immunotherapy or targeted therapy, then we can ascertain if this disease is going to be responsive to that treatment. Once the surgery is done and everything is resected, then doing treatment, there's no way for us to look at that at a pathologic or a microscopic level to see if that treatment has been effective. So this is the gentleman who got this recurrence under the left armpit. This is now the same gentleman who is lying on the table with feet towards us, and this is a cross section of the body at the level of the heart. So this is the right side because the feet are towards us. So this is the right side, this is the left side. and this is the armpit area on the left side. So he was treated with neoadjuvant treatment, and after 2 doses, the result is on the right in the right picture, where this lymph node diminished significantly in size. So that told us that this was a disease that was responding to immunotherapy, and this also made the surgery somewhat easier. When we looked at this under the microscope, this is on the left is the pathology from before surgery. Remember, in pathology, in general, blue is bad. So if there's more blue in the picture, that means those are these abnormal, bizarre-looking cells. These are all melanoma cells. And this is the picture after, where he had had a complete response. So it is all pink, so no disease was left behind. So that's neoadjuvant treatment. So for the recurrence, if it is local and limited, we resect the disease. If it is significant, then we will consider neoadjuvant treatment. If it is still not, if it is still localized to a region. Now, what if it is a distant recurrence? So if it is distant recurrence, now the tumor cells have traveled, and they've taken the highway system, that's the circulatory system, to travel, go elsewhere, take exits, and make new colonies. So now the role of local control at this point has become really none, barring a few exceptions. But really, it is all about systemic control, because this is once it's out of the bag, it can go anywhere, and there may only be some areas that show up on the scans. There may be other areas that we can't even see. So systemic control is with immunotherapy or targeted therapy. This is, remember, we said the T cells, these are part of the immune system. The T cells are the guys that go out, seek out tumor cells by virtue of having this T cell receptor, this green kind of sensor, and they can potentially identify tumor cells as non-self or bad guys and kill them. So how do we harness the efficacy of these T cells? We found out that these T cells have on switches and off switches on their surface, and these switches can then be targeted. We can either turn on the on switches on this side. I just showed 3, but there are like tons of them, and or we can turn off the off switches. So one of the off switches is CTLA4, and a gentleman by the name of Jim Allison found out that by blocking that off switch, we can turn the T cell on. He did get the Nobel Prize for that, and he shared that with Tasuku Honjo, who figured out another off switch called PD-1, and blocking that can result in T cell not being turned off. So at present, we have 3 mechanisms and 4 medicines that are 4 immunotherapy medicines that are approved. Ipilimumab was the first one, also called Yervoy. That is an anti-CTLA4 antibody. Off switch is turned off. Pembrolizumab or Keytruda, nivolumab or Opdivo block the PD-1 off switch and prevent the T cell from switching off. And relatlimab in combination with nivolumab, that is also called Opdualag, is the most recent in terms of the mechanisms. So all of them aim at activating the T cells to go and kill tumors. What is the efficacy? So this is data from the immunotherapy studies with ipilimumab and nivolumab. And again, this is time in months on the bottom and overall survival on the left. This is what the little crosses, the blue crosses represent what used to be the median survival for advanced melanoma, and that used to be about 6 to 9 months, median being the 50% of the individuals were doing okay. So that used to be 6 to 9 months. That is now at 7.5 years is about close to 48%, 50%. And interesting to note that if we look at, this is the 36-month mark, if we enlarge that and look at those folks who did not have progression of disease by 36 months, they actually do remarkably well. So these are the survivals. It's at 95, 96% survival at 7.5 years for those folks who did not progress at the 36-month mark. Kind of alluding to cure. We also talked about targeted therapy. There are a whole bunch of different mechanisms in the body that result in signaling to the cell how and when to divide. This is one of those signaling pathways. Again, I'm not going to belabor, neither is there going to be a test on this material later on, but this is one of the targeting pathways that involves a protein called RAF. So it was found out that 50% of the melanomas have a mutation in the RAF gene, in the BRAF gene. Normally, the signaling should travel along these white arrows from RAS to RAF to MEK to ERK and then the nucleus. But if it is mutated, if the BRAF is mutated, and that's about 50% of the melanomas, then this cell becomes kind of goes on an auto-active schedule, does not require a coordinated signaling pathway, and continues to divide. So medicines, small molecules that were designed to block these links in the signaling pathway. These include the BRAF inhibitors and the MEK inhibitors. Now, using a combination of these BRAF and MEK inhibitors, again, this is the time on the bottom is time in months, and this is percentage alive on the vertical axis. The yellow dots represent what used to be that 6 to 9 month median survival, 50% survival, and that now with the combination of these oral medications is 1/3 of the folks are doing well at 5 years. So clearly, the earlier curves that we saw with improved survival are a result of these newer medicines. I'm just going to finish here. I just want to make folks aware that melanomas are not all in the skin. Skin is the largest organ in the body, so most of the melanocytes, they do live in the skin. But melanocytes can live in other sites in the body and can go out of control. This is on the left is an image of the brain with eyeballs. Again, somebody is lying with feet towards us. This is the right eyeball. We're looking at a cross section at the level of the eyeball. This is the nose in the middle. And you can see this mass growing inside the eyeball. These are ocular melanomas or choroidal melanomas. And on the right, this is a PET scan looking at somebody from one side to the other. So this is the front, this is the back, here's the spine. And what we see out here is an area of activity in the rectum, and these are the mucosal or the melanomas that involve the mucosal or the moist lining of body cavities. So these mucosal and choroidal melanomas behave somewhat differently. compared to the skin or the cutaneous melanomas. They have slightly different mutations, and their management may need to be designed differently. So I don't know where we are with the time. I don't see that, but I will stop here, and I thank you for your attention.